Morning, everybody.
You have to tap it again.
No, you're good. Just keep talking.
Okay. We're going to get started in just a couple minutes. Our speaker is in her car, but ready. I've never done a presentation from my car to it, but she's working
Not
on
in the
it.
car anymore. I am seated and ready to go.
Oh, okay, wonderful. You're on. Well, then let me get started with introductions. Welcome to Cancer Care Delivery. And isn't it great to be back in San Francisco live? I'm pretty excited about it personally. So let me welcome our first speaker. Sam Malangi, MD, MBA, is the incoming medical director of Time Care. And she's going to give us a presentation on achieving whole person care via patient navigation, the Time Care experience. And we thought it would be good to hear what folks out in the private sector who have business models in cancer care delivery are doing to improve care for cancer patients. So Sam, if you are ready, I will turn it over to you.
Awesome. Thank you. And let me just share my screen. You guys can see that okay? Okay, so my name is Samyukta Malangi, or Sam. I'm a third-year fellow at Memorial Sloan Kettering Cancer Center. Throughout fellowship, Dawn Hirschman has been a really phenomenal mentor to me, and it's really an honor to be invited here to speak to you guys. I'm graduating this summer. I'll be joining Time Care as medical director. This presentation was created with slides that were furnished by the Time Care marketing team, so many thanks to them. So Time Care is an oncology population health management company with a core product that is tech-enabled patient navigation. To fulfill the promise of value-based care, the company combines a completely virtual, centrally situated care team, a purpose-built tech platform, and then deep working relationships with primary care groups and oncology practices to achieve value-based care. And I'll speak to each of these strategies in a little bit more detail throughout this presentation. So first, patient navigation. Patient navigation, defined by various professional organizations as individualized assistance offered to patients, families, and caregivers to help overcome health system barriers and facilitate timely access to quality health and psychosocial care. From pre-diagnosis all through the phases of the cancer experience, it was originally designed to reduce barriers to care for those particularly struggling with cancer care disparities, which can manifest as a late presentation or diminished survival. In a variety of studies, which I've listed a few on this slide, randomized clinical trials led by the folks such as Manali Patel, Gabrielle Rock, and others, patient navigation has proven to improve time to treatment, patient well-being, medication adherence, reduce acute care utilization, improved hospice utilization rates, and reduction in total cost of care. But uptake has been less than stellar. Oftentimes, navigation solutions are paid for only in the context of a grant-funded research or pilots, and they're not really scaled on the whole. So why is this? There's probably several possibilities. Payers, who are often the entities to fund these sorts of interventions, can lack oncology-specific expertise. I would add also that healthcare delivery systems sometimes struggle with a culture of incrementalism, and it keeps delivery system innovations from making that leap from pilot to scale. But also to blame really are a lack of technology solutions to power and facilitate population health. Everyone on this call who has worked with an electronic health record knows that those are not designed to facilitate a seamless care experience. They're really designed to power revenue selection. And finally, a lack of aligned incentives that would allow health systems or payers to make those upfront financial incentives in navigation or any other delivery system tool with only the promise of downstream savings. Patient navigation can be kind of a nice to have in a fee-for-service world, but honestly, tools that promise to lower the total cost of care are almost counterintuitive in fee-for-service. So I would say Time Care solves for at least two out of these three impediments. So one, solving for incentive design. Time Care enters into risk-sharing agreements with any risk-bearing entity, whether payers, risk-bearing primary care groups like your Oak Street or your ChenMed, and now actually with oncology groups that are participating in the enhancing oncology model. And it also solves for tech through pulling together world-class engineers, product specialists, data scientists to create a tech product that is probably beyond the scope of development of any one health system at this point. So this is a slide demonstrating a patient journey, and up at the top is sort of a schematic of many patients who are treated in a fee-for-service context without any sorts of wraparound services such as navigation. Oftentimes patients will start off with a possible cancer diagnosis, possibly because they've only yet had a positive screening test or abnormal labs or symptoms that are concerning, but they don't have a definitive tissue diagnosis yet. Sometimes primary care physicians will refer to an oncologist directly, but that referral is made maybe because due to history or habit, but without data that informs the PCP about things like ease of access in terms of timely appointment, geographic convenience to the patient, quality metrics, or cost. And more often than not, there actually is going to be further workup involved, but oncologists, and particularly academic oncologists, sometimes don't see these patients until there's a confirmed tissue diagnosis. So leaving those elements of work up to the referring physician. And then oncologists themselves become handicapped because until they receive outside radiology and outside pathology and have those reviewed by their in-house teams, they often can't get started on treatment. So all these sorts of things lead to delay. They also lead to duplication in work, waste, and ultimately potentially worse patient outcomes. Once a patient is started on a treatment plan, there is a host of both clinical and non-clinical factors that arise over the course of the journey that need to be addressed. Most cancer treatment facilities are not currently engaged in regular proactive symptom outreach, despite a plethora of evidence generated by Ethan Bash and others demonstrating their efficacy, in part, again, because they're not clear mechanisms to bill for these. Some clinics will do one post-chemo outreach call about 2 days after cycle 1, day 1, and that's pretty much the extent of it. Acute care utilization, emergency room utilization and subsequent inpatient admission is very high in cancer. And a recent study that came out of Moffitt that was published in JAMA Network Open found that over half of all ED visits for folks with cancer were identified as potentially preventable. And a full third of these converted into hospitalizations. Pain, for example, was the most common reason for potentially preventable ED visits, clocking in over 36% of all of these visits. And given the cost of cancer treatment and the currently uncapped Part D benefit and the 20% coinsurance on Part B, financial toxicity is extremely prevalent, even for folks who are otherwise middle class or may have quote unquote good insurance. And finally, we don't refer enough to palliative care or discuss advanced care planning with our patients for a multitude of reasons. There's insufficient palliative care staffing. There's a lack of population health dashboards to inform who would benefit. And then honestly, there's a lack of time in clinic visits. So below are the converse, where in a little bit of a self-congratulatory way, where time care can get involved. Essentially, these are all opportunities for improved wraparound care. And the goal is to provide any missing elements through the work of an adjunct team comprised of both clinical personnel and non-clinical lay navigators. So at ASCO Quality last fall, Time Care's Chief Medical Officer, Bobby Green, did present on an internal analysis that used Gabrielle Rock's methodology, analyzing a patient navigation program at University of Alabama in creating propensity matched cohorts, one exposed to Time Care's intervention and one that just comprised of eligible but not enrolled patient control groups, and found tremendous savings in just the first iteration of its care model. And I would say that since then, the care model has actually become even more finely tuned with new workflows and aspects rolling out, such as a palliative care referral program, a new provider entity that allows time care nurses to address urgent care gaps for patients in partner practices, and also developing deeper relationships with going upstream with primary care groups. I wanted to use this opportunity today to actually detail 3 operational challenges that the Time Care team has faced, and describe different tactics that have been tried and other possible solutions that are yet to be trialed. And my hope is that we could just have conversation about the delta that does exist between a good idea as proven in randomized controlled trials and detailed in the literature and its manifestation in real life, with all of its myriad operational challenges and real dollars at play. So the first challenge relates to Time Care's current process in integrating with physician practices. The challenge, of course, is that Time Care is a third party providing navigation services in a virtual only environment. The team needs to be able to have a clinical understanding of the patient's cancer diagnosis and treatment plan and provide services that are complementary to what the clinic staff are doing. And when integrated upstream with primary care groups, the team needs to learn about a new cancer diagnosis quickly to navigate patients through the peri-diagnostic period. To do this tactically, TimeCare has pursued a few strategies. The first relates to clearly segmenting services between physicians and TimeCare teams. So for example, care coordination needs to flow through the clinic, even if floated as an idea by a TimeCare partner, because oncologists ultimately are the ones who would provide referrals, and clinic staff do need to become and remain aware of appointments that are being made on behalf of the patient. So for the team is still trying to understand to what degree they might be cannibalizing the work of clinic staff and the implications of that. TimeCare also works to build relationships with oncology practices with EHR access to better understand patients' clinical situations and needs. So the team has created an API that allows for easy transfer of data from OncoEMR, which is a Flatiron product, and it's pretty much the predominant EMR that is used in many of its current community oncology practices that it's contracted with, onto the TimeCare platform. Getting clinical information through this connection is super useful to TimeCare's navigators and nurses. But that being said, they still have to work it out with clinics about the best way to communicate with them. So for example, recently TimeCare rolled out a palliative care workflow, which involves systematically calculating palliative performance scales on patients informed by an acuity level, an acuity score that is assigned to every single patient on the basis of a number of different variables that are available through claims data, health information exchange data, and then clinical knowledge as we become aware of sort of patients who are describing, symptoms, et cetera. So these palliative performance scales are calculated on every single patient to inform activities such as thinking about who might benefit from a palliative care consult or who might benefit from having an advanced care planning conversation. But the outcome of these activities does need to be relayed back to the oncologist's office. And so what that looks like in practice can differ based on the physician's preferences, but it can mean leaving notes in the electronic health record if we have access, writing a note in TimeCare's EMR, which is Elation, and sending the oncologist a copy, or sending an email or a phone call. Another initiative I would highlight is TimeCare's creation of what they call RAPs, or rapid access pathways, in their work with primary care clinics. The goal of these pathways is to facilitate navigation in the post-screening but pre-confirmatory diagnosis period, enable quick workups and appointments at local oncology clinics that are part of the TimeCare network. Given that navigation in this critical period pays such immense dividends to every player in the ecosystem, TimeCare actually does not take risk or otherwise get paid for the navigation that is done in this portion of the patient's journey. It just allows for a very simple workflow from the primary care physician's perspective. There's really nothing more frustrating than as a physician than having to create different workflows based on something like a patient's insurance. TimeCare understands that community practices benefit somewhat passively from their presence. Patients get an added layer of support at no cost to them or the practice, and through the RAPs, they can also funnel referrals their way, which is generally appreciated because more patient volume. However, the team has found from experience that these efforts are sometimes not enough to influence provider behavior, particularly when it comes to having or working with physicians to consider making drug substitutions or on biosimilars for biologics, or thinking about use of Zometa, which is much, much cheaper than Xgeva. And so part of this is the cultural independence that physicians have in making clinical decisions, but part of it is also that the financial incentives may not be fully aligned with just the way things are set up currently. So going forward, the team plans to include in their contract some form of split and shared savings with practices in their network, provided that certain clinical quality or clinical measures are met. The second challenge that I'd like to discuss is regarding patient enrollment into TimeCare's program and engagement. Again, the challenge is not just being virtual per se, or virtual first per se, especially because virtual teams have become very commonplace during the pandemic. Patients oftentimes now have familiarity with the model. But however, as the company is a different entity, separate from the oncologist's office and paid for really by their payer, I would say the team would need to work overtime to build trust with patients. And so they've experimented with different engagement approaches, leveraging different tactics depending on whether it's a Medicare or a commercial partner. The first step is within that contracting phase to determine whether to go about contracting something like a per member per month contract, per engaged member per month. Although ideally the team would prefer to enter into a shared savings and shared risk arrangement. But these definitions all have big implications for the overall engagement and marketing approach. Segmenting out the patient population that has the highest return on investment in terms of unplanned spend, but also high clinical need, assigning a probability for what is the engagement rate among this patient population with the time care intervention, and then grouping the cohort by these needs archetypes to better orient engagement strategies all represent the early work of this process. Time Care then pursues broad awareness and education via joint marketing between the company and the health plan and or provider practice. So this usually launches with a press release with both national and local focus, blog features detailing the program, co-branded social media posts, Google search ads that are targeted to high member volume zip codes, a program launch mailer to the full member population just to let them know, who the company is and what they would do for them. The team makes sure that they are fully integrated into the payer ecosystem. So the website, welcome packets, the tools around how do you find a doctor. They also take a more targeted approach to building trust and consideration within the eligible population. So the patients who are not only with a cancer diagnosis who are eligible per our program definitions, but who are also on active drug treatment. The care team will use targeted multimodal communications to provide information about the program, including what it entails and examples of member success and how it can benefit them. And so that's really all of the starting point. And they use various channels, phone, text, email, and more. The team has found through experience that it actually takes between 4 to 6 touch points before a patient or member decides to enroll in the time care intervention. During enrollment, there are specialized enrollment specialists who sit adjacent to, but who are not exactly part of the care team, who just perform an initial assessment to identify any urgent needs, housing, food insecurity, high risk symptoms, anything. And then they schedule time with a care partner to begin formal onboarding and assessments to establish personalized goals and a plan of action. And so all in all, this personalized approach does build trust, and it kind of sets the foundation for a successful on-ramp. And then, of course, once a patient is enrolled, then the team also begins communications with their physicians, both the oncologists and the primary care groups, to ensure a collaborative and informed approach. And they send regular updates to providers throughout all of the patient's interactions to fill them on any changes or updates to care. I would say that all of this has led to market-leading enrollment rates. This is based on initial data off of the first 2 contracts that Time Care engaged in, but effectively in the commercial contract, within 3 months, the team was able to onboard over a third of the entire eligible population, which significantly is better than industry standards. For example, Livongo, which is a very common diabetes management tool, averaged 35% over 9 months. And similarly, within Medicare Advantage, there's a really impressive month-over-month conversion, and especially on the folks who are high to medium acuity members. Moving forward, as Time Care looks to partner with practices that are participating in the enhanced oncology model, one idea that has been floated has been to white label the service such that the patient will perceive the Time Care team as a virtual extension of the oncologist's practice, and also to have the oncologist do a warm handoff to Time Care so that patients understand that the team really works in collaboration with their physician. And the final challenge that I will talk about today is using advanced data science to understand and really be able to define what is quote unquote low value care. So the core product, patient navigation, requires a deep understanding of local market dynamics in order to uncover any actionable insights. when you think about high value as a definition, it really needs to comprise both quality and cost. And the cost should be competitive, not just for the payer, but also cognizant of the patient's financial toxicity throughout this process, which can be so considerable in cancer. So in order to deeply understand provider and practice level quality metrics, the data team uses first claims data that is made available through the health plan partnership, and they're able to make decisions around which practices are most likely to meet expectations in terms of delivering high value care. So looking at key metrics around acute care utilization, I'll jump ahead actually to this slide. Acute care utilization, hospice utilization, formulary management, and understanding relative performance in each of these different practices. So then the team develops partnerships with these high value practices based on this data to try and be able to more closely coordinate care for these patients. I will add that, not every practice in a particular market will become part of this aligned network. And all that means is that the team may or may not have full access to the EHR, but they'll still be responsible for the total cost of care of that patient. And so they will still navigate by using all other data sources available to them. And usually that means claims data and health information exchange data, and then data just gleaned from having and building a relationship with the patient. And then on an ongoing basis, the team is able to deliver dashboards of these metrics back to the practices and even structure incentive agreements with them to further improve in areas that are important to the outcomes that they're collectively trying to drive. Going back here. So this is a slide detailing sort of the data that the team is able to deliver to primary care groups. So this is for all of the referring PCP groups on the left, they're able to sort of determine, where are patients being referred, and then ultimately, where are there opportunities for shared patients between the oncology groups that are in our aligned network, and then the primary care groups with whom they're building a relationship as well. So having this understanding of local market dynamics, the composition of care delivery in terms of clinics and hospitals and stuff, the team is able to pilot offerings such as site of service optimization. So for example, if you have a community practice that has certain referral patterns that are possibly set due to personal relationships or historic practice, et cetera, able to suggest different labs, different outpatient radiology imaging centers, different specialist clinic groups based on these metrics of cost and quality. And for patients who say, I'm looking for a different oncology practice because maybe I'm having transportation difficulty, it's just too far from where I live, or I was under the impression I was able to take the bus there, but I'm not able to because there's a change in the route, or there's maybe generally unhappy with the physician, or maybe even just seeking a second opinion. We can optimize those decisions based on geography, based on things like public transportation routes. So really, the team is able to develop a very deep knowledge of local markets. Tactically, I would say that the team has only ever lightly suggested these sorts of options to physicians or to patients who are requesting them. The goal is really to be helpful and not to be heavy-handed. And, with multiple physicians who are part of the executive team at TimeCare, and, the team understands that reducing all of these decisions purely to money is a recipe for physician dissatisfaction. So really ensuring that, anything that we do here is sort of, is packaged as just a light suggestion, and especially only if it's requested. And then really the third tactic to influencing any kind of physician behavior towards high value care is at the point of care. So is basically, the team has developed a Google Chrome extension, which sits on top of the EHRs. It is able to read the content of the page to understand which patient is in context and then present actionable recommendations based on clinical insights. And so this can be used in a variety of ways. One way is for the TimeCare team to notify a physician of an escalated symptom or a potential for referral for palliative care or hospice. And so through that extension, they're able to see the notification in their natural workflow. And it's a type of important communication that doesn't get buried in an inbox or documents page in the EHR. Another way that this could be used, they haven't started this workflow yet, but one opportunity is to present drug substitution opportunities or to make other kind of clinical suggestions that would prompt a provider to make a change in the plan of care that results in more high value care for patients. So, I think in general, when we talk about sort of the plethora and heterogeneity of EHRs that are out in the marketplace, integration between a startup that is seeking to provide adjunctive services and the EHR is always a challenge. And so this Chrome extension is a very kind of an easy bridge between the navigation work that the team is doing and provider point of care decisions. And so, this is just yet another metric that I put in there that I screenshotted from their clinical dashboards that basically shows practice performance on these two particular metrics: end of life chemotherapy usage and then HCC adjusted average total cost of care. There's data showing, not just outside data, but also data that the Time Care team has commissioned with an independent research firm, showing that the majority of patients do not want to disrupt their care team once they have started treatment. So even if that means staying with a practice implies more logistic difficulty or more financial toxicity, there's a great deal of fear that surrounds a cancer diagnosis or treatment, and patients worry about being set back in terms of establishing care with a new physician or losing time between treatments, et cetera. So I want to bring it back to our work about more consistently going upstream in a patient's journey and working with them at the point of a positive screening test. And the goal is that by partnering early in a patient journey, that patients are receptive to any suggestions regarding picking high value providers. And so I hope that this has given everybody some insight into some of the challenges that the team has faced in areas of practice integration, patient engagement, and network optimization, and how they've approached solving those problems. Looking forward, the company will be rapidly expanding into new geographies through contracts with large health networks. So both risk-bearing primary care groups that they themselves are geographically widespread, as well as oncology clinics that are part of large managed service organizations. And so that will upend the current model of deeply penetrating one geographic market in terms of reaching a certain density with payers and providers. And so I think all this hyper growth phase will force Time Care to iterate again on the model to grapple with these challenges related to achieving rapid scale. Just in the few months getting to know the company and understanding the history of their efforts, I've just been so impressed with their deep understanding of the oncology space, which can be so opaque even to those of us who live and work in it every day, and a deeper understanding of the myriad complex decisions that need to be made every day to actually operationalize this really cool concept of patient navigation. So that is the end of my presentation. Thank you so much for your time.
So, I guess this is on. All right. First of all, thank you so much for that presentation. Sam is one of those fellows that reached out to me during her fellowship, asked for mentorship, and it was really she who mentored me. So it's so great to see what she's accomplished. So, in this committee in cancer care delivery, we sort of work to try to test the efficacy of interventions. And one of the things that always comes up is, can we really test models of care through our traditional methods of randomized clinical trials, or do we do it at a bigger level, like a policy level, or a company level that really can integrate like Time Care? And so one of the questions I guess I had in hearing your presentation is, now that this has been implemented, what strategies, can we use from a research perspective to figure out how to maximize it or understand the processes where it works best and it does not work best?
Yeah, it's a great question. I will say that even in just preparing to onboard into this role, I've done a lot of reading about sort of research opportunities and helping the team, test their efficacy and prove it. Because they are in primarily Medicare Advantage contracts right now, I have found that it's actually quite challenging to find a comparable, control population with which to sort of demonstrate in a rigorous research context the efficacy of this intervention. Firstly, Medicare Advantage is a managed population. So even as we compare across different geographies, if a certain payer is able to give us data from a different market, it's very possible that there are utilization management or patient selection strategies already in place that make kind of like an apples to apple comparison very difficult. And then, I've spoken with places like, or companies like MarketScan or Milliman, or even the CMS ResDAC to try and understand what proportion of their repository is MA lives. And I have found that it's actually quite small, and they themselves have advised me not to pursue that avenue. And so thinking about you have now MA lives comprising more than half of all Medicare lives in this country. And there's not like a clear way in which to do a differences designed just because of the lack of a control population. And so one thing that I have been thinking about is trying to figure out, can you create control populations within your existing markets around, patients who might be eligible for your intervention, but who are not enrolled for any given reason, and trying to understand whether those populations can possibly be comparable. But I think it's sort of these types of design elements that I know that companies like TimeCare honestly need the advice and assistance of experienced researchers in the room, because they, are not researchers, but they need to prove their efficacy, and trying to figure out how to do that in a very fast-paced context without, a lot of room or margin for delay is I think critical.
Thanks. And let me mention to the audience that if you'd like to ask a question, you can just come up to the mic and Sam will be able to hear you. I had another question for you. We both share the challenges of trying to identify patients who are eligible for our interventions and then get them to sign up. It sounds like you have TimeCare has some particular advantages in that you have access to OncoEMR. But I wasn't quite sure how you actually got to the patients, since you're virtual and, reached out to them. And you mentioned that it took, several tries often before a patient would engage. Can you just walk us through a little bit more on how you identify and then consent, if you will, patients to sign up for your service?
Yeah, 100%. So I would say that the TimeCare team becomes responsible for a population of patients within just taking into account like an MA population. I think roughly less than 3% of patients meet the program criteria in terms of having an eligible cancer diagnosis and then also being on active drug therapy. So that removes a lot of in situ cancers, et cetera. The team will ultimately become responsible for this entire population. But, because of the nature of claims data, there can be a delay, especially for folks with a new diagnosis, in terms of the team, if they just relied on claims becoming aware of these patients. And so there's two strategies that the team pursues in order to try and identify these patients earlier. One is through building these relationships with oncology practices in a given geographic market, and then trying to say, we ultimately are responsible for these patients. And so we will become aware of them maybe in a month's time, but it would help us out a lot if you were to be able to just let us know that there's a new patient just been referred or a brand new diagnosis, et cetera. And then that way we can reach out to that person and explain, who the team is and how they work in concert with the oncology practice. So having that handoff from an oncology group is important, and it drives many of the reasons why the team tries to establish deeper relationships with these oncology groups. Another way that the team can become aware of a relatively new diagnosis of cancer is through logic that some payers use in prior authorization data. So like Cigna, for example, or Humana, I can't remember, the team told me about this once, but basically they have built out rules-based logic around prior auth data for things like imaging studies following maybe a previous imaging study or a procedure following an imaging study, or patient age groups and sort of like smoking status, et cetera. All of those things kind of get plugged in, and then there is a hypothesis that somebody may have a new diagnosis of cancer based on the workup that is being done. And so when I think this is a strategy that is relatively new to the Time Care team, but that is also a way in which the team can become aware of a patient relatively early into their journey with cancer, and reach out. And like I said, I in terms of securing consent, it is during that initial enrollment call where there's explanation about kind of what the team is and does the patient consent to being enrolled and what that would involve, et cetera.
So we have time for one really quick question before we move on. So, Mark.
Mark O'Rourke from Greenville. Just to follow up on your last comment and the last question, what decision does the patient make to enroll? You mentioned the positive metric of 33% signing up within a short interval of time, but what does the patient have to do or have to decide to enroll?
I think the patient it's at no cost to the patient. It's also at no cost to the practice. I think sometimes there's really nothing in terms of like a true downside in terms of enrolling in the program from the perspective of a patient. But I think sometimes there's like trust issues, or if trusting a third party program that is affiliated with the payer. Sometimes there is just a feeling that the patient doesn't feel like there's any true needs that need to be addressed, particularly social determinants of health needs, et cetera, that come top of mind in that initial decision-making process. And so I think there are a few reasons, but those typically are the ones.
I mean, it always seems like there's no free lunch, right? So it's no cost to the patient and no cost to the practice. Really, it's important to keep in mind that it's the incentive of the insurance company to try to keep the costs down, right? Because they're paying directly. But a lot of people, I think there are other programs out there where there is a cost to the practice, right? Because the practice is what's paying per month. And so as we start to think about these improved models for care delivery at the more at the policy level or external vendor level, I think it's important to keep in mind always like who's benefiting, right? Who's going to benefit from the intervention? And ideally it would be everybody, but that's not always the case. So thank you so much. We really appreciate these insights for the people in the room, which is quite large, and also the 69 people online. Thank you for joining us this morning. As we hear these presentations, I'm hoping that people in the room start to think about research questions and how we can pivot or partner with the presenters to think about new initiatives that we can do within SWOG. You want to introduce?
Sure. All right, let's move on to our next speaker, Dr. Justin Beckelman, who is director of the Penn Telehealth Research Center of Excellence at the University of Pennsylvania. And he's going to be talking to us today about his work in telehealth.
Good morning, everybody. Thanks for joining. That was an awesome presentation from colleagues at Time. That's awesome. I'm presenting on behalf of Dr. Bachani and Dr. Rendell. We multi-PI this grant. This is a really nice opportunity that complements the earlier presentation today. What I thought I'd do is give some really practical study design overview for this P-level grant that is funded by the Moonshot. We're one of 4 telehealth P50s funded by the Moonshot and represent sort of the NCI and Moonshot investment in telehealth and cancer care currently. I should acknowledge that there are a number of R01, Ks, and then there's a tremendous evidence base for telehealth in care delivery that's beyond this program that we leverage as well as we thought through what we're trying to do. So with that, I'll try to present this relatively quickly and leave time for discussion on the study design given the group here. And potentially your interests in driving this type of work forward. So the goal here was to do like a mashup of interdisciplinary work across communication science and behavioral economics, incorporating a test of telehealth strategies across the cancer care continuum. We found great success in and this idea of creating great science through mashing across disciplines rather than within disciplines, and I hope to be able to share that with you today. The entire program is focused around lung cancer as an exemplar model for telehealth, and is also underpinned by a commitment to health equity in its design, evaluation, and reporting, which I'll be able to share with you today. These types of grants are massive. It's a huge team. We're very proud and fortunate to be part of the team. It's an interdisciplinary team of folks that many of whom you will recognize in these photos of cancer care delivery researchers, communication scientists, behavioral economists, and people with expertise in healthcare innovation as well as health equity. When these Ps are proposed, they typically have cores as part of them, and all level set to, I recognize many of you in the audience may hold these, but I thought I'd share some of this to give sort of an insight into how these are constructed and what these look like for folks who are not as familiar with P-level grants. There's usually an administrative core and then a research and methods core. In this particular context, I'll share with you the middle of the research and methods core, where we have a pragmatic trial, a pilot project, and then a second pilot project. The pragmatic trial, I'll signal these for you because it'll transit through the presentation, is around shared decision-making for lung cancer screening. The pilot project is around comprehensive molecular testing for patients with lung cancer. And then the second pilot project is designed as sort of open and will be revealed through interests of investigators and junior investigators throughout the term of the grant, which is a 5-year grant, which will likely be in either treatment, survivorship, or palliative care. And then I'll direct your attention to the left-hand corner, the clinical practice network. This is also now a part of these care delivery Ps that are coming out of the NCI, where they're asking us to describe what is the sort of innovation laboratory, the clinical practice network within which your science is embedded. In this case, it's within the primary care service line that spans 3 states of Penn Medicine, and then the oncology or the cancer service line as well. We use the term innovation laboratory when we speak to scientists, and the term laboratory is understood by basic to translational and trialists, et cetera. But we're careful in how we describe this in communities when we talk about implementation laboratories or innovation laboratories, and we're doing community engaged work. Those words can be heard very differently. And so we typically change the way we talk about our network and talk more about how our focus is on community engagement. I wanted to share with you a new conceptual model that we proposed as part of the grant that we intend to now publish in coordination with the 3 other telehealth Ps that are around the country. This is the FIGHT model. It's the framework for integrating telehealth equitably. We developed the FIGHT model because when we looked at the models of community engagement, health equity implementation science, patient-centered communication in cancer care, that none of them we felt suited to the new science of telehealth. And so we developed a model that leveraged, the prior ones, we sort of stand on the shoulders of thought leaders from before, but we believe that this model is helpful and drives our science, and we're looking forward to the peer review process and getting some feedback on it. In this context, you'll see a lot of implementation science themes here. We first conceive of the digital divide sort of differently than it's talked about in the popular media and the lay world. Many people say, well, the digital divide is about not having iPhones or not having access to computers and technology. We believe access is an issue, but it's a smaller issue, often more prominent in rural areas. And it's only part of the issue. We define the digital divide as a components of 3 different areas: access equity, skills equity, and empowerment equity. Access equity is geared to ensure access to telehealth by reducing friction in how people access telehealth, whether it's through in the end, phones, if necessary, iPhones or I should say tech-enabled phones or computers. Skills equity equally important. It's not enough just to have access to the tech. Patients have to have the skills to use the tech appropriately. So our focus in designing these trials was to design these strategies to make sure that patients have the skill sets and are able and facilitate navigating through barriers to using the tools that they have available in front of them. The last is empowerment equity. You can have access, you can have skills, but if patients don't feel empowered to use the tech, then they may not be interested or telehealth may not actually induce access in the way we believe it will. So we use this model to inform the strategies that I'll show you shortly that we think will impact on the patient-clinician encounter and ultimately lead to both digital equity and then health equity. And of course, as good implementation scientists, we're led by Dr. Rendell, who's actually a card-carrying implementation science. I'm not. But she has led this work and places this work within an inner and outer context and the societal context. Folks will recognize those terms from the field of implementation science. I'm happy to talk more about what they mean if we want to double click on that during questions. So let me go into 2 use cases. First, I'll present on lung cancer screening. I'll level set a little bit. I'll then present on molecular testing, level set a little bit, and show you the design of the trials. The basic, so I'm a radiation oncologist. I treat mostly men with prostate cancer. The highlight for folks who are not in the screening space or not in the lung cancer screening space is that we have screening tests, low dose CAT scans that work reasonably well, that are incredibly poorly adopted, and even more so for patients from brown and Black communities. That's the summary. There are statistics that 5 to 10% of patients eligible for lung cancer screening actually receive it. It's interesting, phase 3 trials demonstrated that lung cancer screening was effective. It's the only level 1 evidence screening modality that requires a shared decision-making conversation for reimbursement to actually proceed with lung cancer screening. So for example, when you go to mammography for breast cancer screening or colonoscopy, both level 1 evidence, just like lung cancer screening, there's no billing code for shared decision-making, sort of a gating process that patients and doctors have to go through to order it. Doctors just order it. But with lung cancer, there is at the level of CMS and then shared across commercial payers. There's an expectation that there is shared decision-making. A shared decision-making visit occurs prior to lung cancer screening. And so we are optimizing within the context of the payment environment. But you can hear my own personal perspective is that shared decision-making conversation, important, of course, but as part of a billing process, perhaps poorly situated. So what are the aims? I'll briefly talk about these, but what I'm really going to do is show you our trial design, which is super fun. And I know leverages a design that you're very familiar with within SWOG, but I thought that it'd be an area for great discussion. So in the pragmatic trial, which is the largest trial as part of the program, we are using a patient-level pragmatic smart design, and I'll talk a little bit more about that in the context of the trial, to determine the effectiveness of telehealth strategies to increase shared decision-making visits for patients eligible for lung cancer screening. So the target here is shared decision-making as a result of my earlier discussion. Of course, we will also track the clinical outcome, which is important, lung cancer, low-dose CAT scan, lung cancer screening, as well as access, timeliness, implementation costs, other factors that will inform wide-scale implementation should this trial be successful. A secondary aim, which we're powered for, is to assess equity by race and sex using non-inferiority testing. I can talk about that more. The hypothesis here is that the probability of shared decision-making completion in the historically lower rate group, Black or female, based on prior eligibility guidelines, is inferior, and rejection of the null will provide evidence of non-inferiority. In other words, we are suggesting that our strategies work similarly between groups historically in well-served medical communities and historically in underserved medical community. Aim 3, evaluate multi-level mechanisms contributing to the quality and effectiveness of telehealth strategies using a technique called qualitative comparative analysis. And if we have time, I'll make sure to talk about that as well. So here's the design. I'll focus a little bit on this and then move into some other areas. And I know we want to keep on time. And so I may also end up short-circuiting other parts of the talk to open up time for discussion. So components of the SMART design. So first, in the stage 1 intervention, patients eligible for lung cancer screening. So this is the non-cancer population in primary care. We expect to have at least 9,000 patients at stage 1 across a population of patients that is probably around 40 to 50,000 across our primary care service line. So 9,000 patients randomly assigned to telehealth shared decision-making only versus the active choice of deciding, do they want to have shared decision-making over telehealth or do they want to have it with their primary care doctor? Stage 2, if there's no scheduled shared decision-making or if it's scheduled. So in other words, no scheduled shared decision-making. If we fail, quote unquote, fail stage 1, this is the SMART design. Patients are then re-randomized. If they're not scheduled, they're re-randomized to a stage 2 intervention, which is a digital care coordination, sort of high touch versus a frame messaging, low touch. That study design allows us to have 6 different categories in the end that combine. It's a stage 1 randomization and then a stage 2 randomization across 2 different groups who, quote unquote, fail stage 1 randomization. This is a particularly, we've received feedback that this is a particularly interesting sort of novel use of the SMART design. I think it's a way to think about using these types of, there's sort of adaptive designs moving forward in pragmatic clinical trials and the kind of work that we all do together in cancer care delivery research. And so I thought I'd spend a little time on it. The second context is molecular testing in non-small cell lung cancer. Just very briefly, genotyping of newly diagnosed folks who have advanced non-small cell lung cancer is now becoming more and more sort of prominent and only will become more prominent over time to guide therapy. And when patients develop progression on targeted therapy, then liquid biopsies can be utilized to identify potential mechanisms of resistance. I've come to understand and know better the clinical space here, and so I recognize the use of liquid biopsies in the context of advanced lung cancer diagnosis is controversial. There's NCCN guidance about it. Penn is a particularly sort of plasma-based biopsy testing forward institution. I'm happy to talk about the clinical aspects, but wanted to share how we're actually testing telehealth in this context. So the aim here is to test the effectiveness of synchronous telehealth nurse navigation compared to usual care to foster what we call timely molecularly informed treatment recommendations through early integration of comprehensive molecular testing. What the NCI loved about this is that we were combining something that's so scientifically of interest, sort of across campus, plasma-based molecular testing with a care delivery experiment effectively within cancer control. And a wonderful piece of feedback we received is the more that cancer care delivery researchers can be on the cutting edge of care delivery innovation, but also be testing things that are coming out of the wet lab science or the translational science aspects of NCI will make the NCI even more excited. So what's the schema for this? Basically, patients who are at risk for an advanced lung cancer by chest X-ray or however it is suspected, stage 3 or metastatic non-small cell lung cancer typically proceed with a biopsy. At that time, patients are then randomized to a usual care arm versus a telehealth care arm. In the usual care arm, they would have a tissue biopsy. Typically at Penn, they would undergo some type of nurse navigation possible plus plasma-based molecular testing, a med-onc visit, and first-line therapy. We find that there are several weeks of delay there for some patients. In this intervention arm, in the telehealth arm, we sort of move the front door. That's the goal of this program. We move the front door, move access to telehealth through telehealth to nurse navigation sooner, even before the biopsy, through patient education, allowing us to have a obviously more informed patient, but also allowing us to conduct plasma-based molecular testing at the time of the tissue biopsy, a concurrent intervention that we believe will yield more timely molecularly informed treatment decisions and move up the pace of care, ultimately affecting both toxicity and potentially lung cancer survival. So I'm noting the time. It's just a couple minutes of the top of the hour. And so what I thought I would do is end here on rapid cycle approaches around innovation and then pause for discussion and questions. More and more, we're finding that the NCI is interested in taking lessons learned from what we call the discipline of innovation or rapid cycle testing and moving it into the research program. And they've hosted seminars on this. They've begun to bring in, even folks from industry to say, well, how do we think about this? And we have, I think, a lot of sort of intellectual strengths in this area. And I want to share a little bit about how we think about it. When people say, well, let's bring rapid cycle testing into the conduct of randomized trials, it's sort of like, well, what does that mean? And one way to think about it is that it often happens before the first patient in, and the whole purpose is to de-risk or optimize strategies quickly before first patients are into clinical trials, to avoid the issue of needing to create changes or drag on the trial once the trial is up and running. There are frameworks for this. One that we use at Penn is called the Double Diamond Framework. We didn't invent the Double Diamond Framework. It comes from the area of design and human-centered design. We've tailored it into healthcare. When you think about it, it comes down to pretty simple stuff, but these kinds of frameworks help research teams understand the process and also help express to funders how we actually conduct innovation or rapid cycle testing, rapid cycle approaches as part of clinical research. In this case, we've defined 4 phases: contextual inquiry, problem definition, exploration of alternatives, and rapid validation. If there's interest in this area as well, I'm happy to double click on this as well in the context of this group that's focused on clinical trials and cancer care delivery. So with that, Scott, I'll turn it back to you. I'll stop sharing. I'm happy to answer questions.
Justin, thanks so much. That was a great presentation. Everyone here is keyed up, and I think I'll turn it over to Rick Bangs, who looks like he has the first question.
Hi, I'm the chair of the Patient Advocacy Committee, and I'm really excited about your presentation. One question I would have is whether there's been consideration or monitor, or there would be monitoring of the integration of other family members or friends who tend to be part of this. It seems like telehealth would offer that option, particularly for people who are not co-located, a family member or a friend that's not going to be in the office versus being in the office where you have to be co-located. So that's my question, is whether that's been considered.
This is just a huge area of research. And for junior investigators who are in the audience here, this is such a great opportunity. I'll tell you why. We are now able to understand and record consultations, whereas previously they all happened behind a closed door. So as part of that, we can assess how many people are on the telehealth call, how many voices, what's the quote unquote temperature of the voices, right? This is all through analytics, big data stuff. Temperature being, do the voices sound stressed, right? I mean, this area of research is unexplored, but it is it's huge. We can also assess from a big data standpoint, across our hundreds of thousands of telehealth visits, we know how many of those visits were multiple sign-ons used. So in other words, someone from work and someone from home. We know the bit rate for each of them. We can assess whether sort of glitchy telehealth is associated with social needs, and whether glitchy telehealth reduces communication, then is ultimately associated with glitchy telehealth is ultimately associated with outcomes. One area of our research team is now considering, like, can we de-identify telehealth encounters, effectively make avatars of those involved in order to protect their privacy, but allow us to understand the quality of communication that happens within care delivery. Whereas before, we could only, get a doctor's report. Yeah, it was a decent conversation. Or we go to Press Ganey and the patient says, that was horrible. And the doc's like, nah, I think that was really, their issue. They were running late, right? Now we can actually look. For radiation oncologists in the room, this is effectively like having your DICOM images, right? We can understand exactly what our treatment plans are. Unlike surgery more and more will have video. But in radiation oncology, for decades, we've been able to sort of capture our treatment. Now we can capture our interactions. This is a huge area of research. I didn't answer your question directly, except to say the potential for assessing that with our own research program, but within, hopefully I'm inspiring folks in the audience within your own, it's dramatic.
Thank you.
Mm-hmm.
Justin, this is Dawn. I have a question. Sometimes when we propose similar models like you've done for your smart designs, a lot of the feedback we get is that it's too complicated, it can't be done, it's not, you're gonna lose data, it's not going to be interpretable. Maybe you could spend a couple of minutes just talking about the implementation of that design, if you don't mind.
Yeah. Yeah, I've heard those concerns before. They didn't manifest in this particular proposal in the reviewer feedback. And so I'm actually pausing to understand why that was. It's something I hadn't really thought about, but Dawn, I've heard those before. I mean, part of what we're assessing here is accessible within the EHR. So regardless of the, randomizations, where our data set's going to be, it's going to be good. It's not going to be great. It has to be clean, but our data set's going to be good. The documentation of shared decision-making visits is going to be very clear because it's billed, et cetera. We've also standardized the approach by which we would be conducting sort of central telehealth shared decision-making as an example, and therefore can, in a way, control some of those data, missingness issues because of the way we're centrally organizing it. So I think that the reviewer's concerns about the design may not have to be put in the context of the entire design of the research program and how the investigators have sort of expressed their handling of missing data and things like that.
Oops, we've got one more question. Go ahead, Matt.
Keep it very brief.
Yeah. I appreciate the time. Thank you, Doctor, for your presentation. Could you please unpack your evaluation metrics for a shared decision-making visit?
Sure. So we have a great stakeholder group, and hilariously, we asked them, and one of them said to us, "Well, you'll know shared decision-making is successful if the patient gets a low-dose CAT scan." And I love that. Now, that's my personal bias. That's my personal bias, obviously. But in the world of lung cancer screening, I recognize how important shared decision-making quality is. And so we have an instrument to sort of a standardized instrument that assesses shared decision-making quality and will be assessed from both the perspective of the provider, but as well as the patient.
Great. Well, Justin, thanks so much. That was a wonderful talk. Exactly the kind of thing we're interested in here. And I hope it does motivate some of our folks to think about some of the work he and his group are doing. Is it okay if folks reach out to you after this?
Oh, please. And I have to tell you, we'd be delighted to work with SWOG. I think of all the cooperative groups, SWOG is the strongest truly in doing care delivery innovation. And I can't tell you the number of mentees I've sent your way to say, hey, can we embed this trial within the SWOG organization? So delighted to talk with folks who are interested to talk about this or other aspects of the programs we do. Thanks very much.
Great. And I can vouch for Justin as an awesome, awesome mentor and a wonderful person. So take him up on that offer. Thank you, Justin.
Yeah, take care.
So now we're going to move on to updates on our active studies. Again, I hope that some of those talks give people some insights in terms of different projects that they can pursue.
So I'm presenting on behalf of Dr. Veena Shankaran about 1912 CD, our credit study, which is, as you might remember, a randomized trial addressing cancer-related financial hardship through a proactive financial navigation program. So the original study scheme was to enroll a patient and a spouse in a partner dyad to either be in the control group, which was standard financial literacy training, or an intervention, which included direct medical cost coverage, financial counseling, and financial literacy training. Since this study started enrolling, it's had a lot of challenges getting patients enrolled and their dyads. And as a result, we worked with NCI to make some study modifications. NCI has approved the restructure, and it's going to make significant changes that I hope will improve enrollment and streamline delivery of the intervention. So it's currently being reviewed by the CIRB. I'm hoping we'll get that back soon, their ruling. But just suffice to say, for those of you who have looked at this intervention at your clinic, there's some key issues that I think will make it simpler. First of all, we're dropping the spouse caregiver participation. So if the patient either doesn't have a spouse or doesn't care to have the spouse involved, or the spouse doesn't want to be involved, that's fine. They can still enroll in the study. And our understanding is that was one of the major sticking points. We've also reduced the target sample size, and it will still preserve power. And then finally, Sense, which was a Seattle-based financial counseling group, was providing financial navigation. There were some challenges working with Sense. They're a very small organization. So we've switched the primary financial navigation partner to the Patient Assistance Foundation, which is a much larger national group. And we think that will facilitate the facilitation and make it easier for the patient and or their partner. So my team is off to the left. They're waving. And I'm hoping some of you will walk over there after this. They've got handouts that'll summarize the changes. You can reach out to Dr. Shankaran directly, or email us here. You can also reach out to me, and we can give you more information about the changes in the study. But we're eager to get this going in the summer. So we're hoping that some of you that may have had challenges or had hesitation to be part of this will reconsider. All right, next is 2108 CD, Enhanced Genetic Tumor Board. Dr. Luger.
Thanks, Scott. Thanks, everyone. Just presenting very quickly. Magna and myself are both here, and we're happy to answer any other questions. And you can meet us also after the session, and we can talk through some questions or any other issues that you may have. So just as a reminder, this is the study design. That's a cluster randomized study, and we're looking at the impact of educationally enhanced genomic tumor boards compared to usual practice. It's a cluster randomized study, as you can see here, with the primary endpoint being proportion of patients that started an evidence-based genome-informed therapy at 6 months. And we have been up and running since, well, the study was activated in August of last year. We started enrollment in November, and we'll get to the enrollment in just a second. These are the recruitment centers that are all onboarded at this point. You can see it's all across the country, with some focus there in the middle of the country, of course, but very excited about this sort of diverse set of practices that is participating in the study. This is our current accrual, and we're actually very excited about the accrual and where we are. So thank you, all of you, for enrolling patients on the study. So this is the status as of April 18th, when we had enrolled 246 patients. You can see it's probably a little bit small on the screens, but you can see how the accrual of patients is really kind of going up very nicely. When I just looked again this morning, we're now at 313, I believe, which is 27% of the target enrollment. The line in yellow here, by the way, is the number of physicians, which is expected to be somewhere around there. There's not necessarily a set point, but this is where we are. I think just a few words. We've made a few changes along the way. We've had to adapt and also do some education on how to best approach and enroll patients on the study. We've had monthly teleconferences. We got great feedback from many of you on some of the challenges. I hope we have addressed most of them as much as we can. And we're looking forward to continued enrollment to the study. So thank you. Again, here is the contact information for all of us, the different emails, but again, we'll be around after the meeting and happy to chat. And I've already talked to a few of you, or we've already talked to a few of you over the, earlier this morning. So yeah, that's it. Thank you.
Before you hop down.
Okay, sure.
How have the tumor boards been going in general?
They've been going very well. So one of the questions that we had in the very beginning is how would we manage sort of the workflow and the incoming cases. I think some of the concerns were, what is the timeline between a patient being enrolled and the tumor board being held. We have a dedicated coordinator for this job who's been great, Johannes Fischer, who's can also be reached here by email. And I think that has worked quite well. So we have on average about 6 or 7 cases per genomic tumor board. So the caseload has been fine. We've been able to work through the cases, I think, in a meaningful way. I think the physicians have been very thankful for the advice and the input that they're getting from the tumor board itself. So I think it's worked well. We had as you could see as you can see here, we've had quite the bump in enrollment in the month of April. So we just actually added on an additional tumor board session, and we were also able to do that relatively easily. We have various time points during the week and various days of the week that rotate. I think it's worked quite well in terms of physician participation, or there are some sites where that's a challenge, but the protocol allows for having a site representative there to present the case, and I think it's worked quite well from that end as well.
And one final question, are you still looking for more clinics, or are you at steady state?
Well, we are currently, we are replacing one recruitment center, but we already have 2 backup recruitment centers lined up that we're just waiting to finalize the randomization procedure. So we're not looking actively at the moment, although if there are interested sites, email us, because we will need backup sites again, because we don't have any more backup sites now.
And I don't know if you've already heard this comment this morning, but yesterday there was a discussion, because you have a great representation of rural areas here, the inclusion of advanced practice providers, physician assistant, nurse practitioners, being able to sign off on eligibility and things. There was some discussion. I don't know if that's been brought up yet.
That I don't think we've discussed yet. No.
Love for anybody in the room who was discussing. I know the Hawaii NCORE had some comments about that, just how it might help facilitate with some slight adjustments there.
Great, thank you. Yeah, we'll definitely happy to consider that.
So on the chat, we got a comment that The patients at the Carl love this study. I guess they're at one of the sites. This is a great example of a patient and site-friendly study. And so, you know, as we think about designing studies, we really do need to think about, you know, we do so many studies where we open them up and we're like, oh, we're going to be able, this is going to be no problem. And, you know, lo and behold, nobody accrues. And then other studies where we're like, oh, can we do this? And then it takes off. And so it's really good to do like a deep dive in terms of really sort of thinking about the power of the NCORE and the NCTN and what we can accomplish. You know, it's a testament to you and Meghna because, you know, these trials are like a labor of love and they do take a lot of effort, but we really hope that this will be an impetus for more studies like this to show what we can do. And so I would say, you know, it's good to put together your lessons learned and start thinking early about the next steps in terms of what we can do, because this is going to be done before you know it, thank goodness. I guess, you know, also think about, what advice you would give other junior faculty or other faculty that were putting this together. I know the two of you did not have an R01 to do this grant. You did it really on your own. You know, you had some support from the Hope Foundation, I think, which was probably really helpful. So thanks to anybody that's thinking about donating money, donate to the Hope Foundation, you know, because it really has a high impact. And, you know, if there's any advice you would give other junior faculty that have an idea like this in their head.
Well, I can say one thing. I was going to actually reflect on one thing very concretely that came up to this comment. So the Carl NCORE is actually one of the usual care sites. And so what that means is basically you enroll patients and the physicians do have to answer some surveys, but otherwise there's no quote unquote benefit. And that was actually one of the concerns that we had in the beginning. Would accrual to the usual care arm be an issue? And it turns out it isn't, as you can actually see by this graph breakdown already. There is actually currently, there are more patients enrolled at the usual care arm, which I thought was actually an interesting lesson learned, because certainly not anticipated. And the great thing that I will say, I think it came from Carl, is that we heard that when talking about the study with patients, the patients really loved the idea, and this was how it was presented to them, that the study would be about testing their physicians' knowledge about genomic tumor testing, and the patients think that's a great idea, right? So, so that's one lesson learned there is, you know, think about how, yes, you think about what the impact is on the site, but then also what, you know, how do you best communicate a study to patients, I think is really important. And I think, so that's an interesting comment in that, along those lines. And there are probably many other lessons learned that we can share. So happy to do that.
Well, thank you both for, you know, all of your hard work and dedication. You know, I think it's like a long, slow up ramp, and
Yes.
then you know, it pays off at the end. And so when we think about doing these studies, it's important not to get discouraged.
Right.
Because, you know, if we all remember, your very first concept was disapproved.
Right.
So it's really
time.
important for people to realize that perseverance and persistence are really worth
Yeah.
it.
Well, thanks, Don and Scott,
Yeah,
for
and
your support.
this is going to, I think, be a model for remote physician support of very complex patient decision making. So,
Right.
yeah, props to you all.
Thank you. Thanks, everyone.
Okay, our next study is 1703, Melissa Accredino, non-inferiority trial comparing survival of patients monitored with serum tumor markers versus usual care.
So good morning, and I think this is another trial that we need to think about persistence and opportunities to engage this group. So here's our schema, and again, this is our study about how to monitor patients with first-line hormone receptor positive, HER2 negative metastatic breast cancer, either using serum tumor marker directed monitoring versus usual care. So here's our accrual to date as of the last week of April. And this is a two-step registration study. For step one, our aim is for 1,300 100 patients. We are slowly making some progress, but there's a lot of opportunity here for people to become engaged. So if you don't have this study open, it's a very easy study to conduct and to do in clinics. We have some great tools available that Eric and Claire, who are sitting over there, have put together that can help make this kind of go on autopilot. And a lot of these study visits are when the patients are already coming into clinic. So it's very easy to do. And we think that this is a really important question, how to best monitor these patients. So, you know, if you want to get involved, there's still plenty of time to get involved. And please think of this study when you're seeing patients, especially when you're starting a new CDK4/6 inhibitor, you know, keep in mind to check tumor markers and think if these patients might be eligible. We have some new study tools available. So we have a clinical trial summary that is CIRB approved. It's patient friendly. It's written by the SWOG plain language expert. It can be found on the website. This is a really great tool to give to patients to help them understand what the study is, why we're doing this, why this is so important to do, and who can participate. So hopefully this can help. There's also some materials if you want to promote the study on social media. We had a Twitter campaign that launched over the fall, but if you want to use any of this for your own sites, there is a toolkit available. And again, this is just more information on the patient recruitment flyer. I don't know if anyone has used these in the clinic, if anyone has any comments. We are taking steps to improve accrual. We have identified a champion from the Alliance. We're still working with ECOG Akron to get a champion from there. We do allow remote consent. We are having regular webinars to address any issues. And I know that Joe, who is missed very greatly at this meeting, but I know he's joining us on Zoom, is working to update our non-inferiority margin. So we hope to get the overall sample size down based on that. Some successful strategies that we've seen and have come up on some of these calls have been screening patients who have a new prescription for a CDK4/6 inhibitor, because often these are the patients who are eligible. Coordinating with how your workflow is by screening all patients versus provider referrals versus a mix, depending on how your clinic works. Some clinics are using pathology reports to screen for positive patients, coordinator emails, EMR alerts, and also making sure that we communicate the message with the patients. I think it's really important when the providers are speaking, just to really identify that there is no known right way to monitor patients with metastatic breast cancer. And we're really trying to find the most patient-friendly approach to go forward with strong data. So if anyone has any further ideas, we are here and we are welcome feedback, and here's our contact information.
I just want to make a plug, and she may be in the room, but Jennifer Meiser, who used to be our recruitment and retention specialist, has been replaced. So if Jamie Sundram is in the room, she's available to help any trial with their recruitment strategies, particularly one that's needs some help. Right. So I don't know if you've reached out to her. I saw a long laundry list of countermeasures, but she's a free resource to all of us.
Yes, and we have been working with her, and reports to individual sites are going to be forthcoming. And I see Diane right there.
I have flyers. If anybody is interested, I did make up a little bit of a flyer, so I'm back here. So come and see me or just let me know.
Hi, just a quick comment, and I think we talked about this in terms of what are the patient thinking. And recently I had a metastatic patient in a meeting with me, and I was talking about this study, and she's like, that is great. I will participate, but not give away my scans, right? So they're still, because we don't have the data, but that's what they know up to now, that the scans are the things that are going to keep them knowing and if they progress or not. So she was very excited about the idea. But she said she won't do it leaving the scan. So, and I think that has been part of, because they don't know better, and that's what you're trying to find, right? And
exactly,
and trying to explain that, you know, any suspicious or worry that the physician will have, they will be able to intervene. But it still, it proved what I was telling you when I discussed
Yes,
this.
absolutely. And I also think it's really important for us as providers to really address that with patients, that we, one, for the study, if there are any signs or symptoms, even if patients' tumor markers are completely normal, that they can get a scan for any reason at any time. This is really just for routine surveillance imaging. But we don't know the right way, and we don't know if scanning all the time is helping those patients. There's a lot of negativity associated with scans, right? Oftentimes we're using contrast, which can have negative effects. Patients have to come to the hospital and park their cars, which can sometimes have expense. They might need childcare for the day. Then there's the mental tolls in terms of scanxiety and waiting for the results and what that might mean when there's things that are found on the scans that may not mean things, especially now that the results are instantly released to patients and they read line by line and they might not have a follow-up with their doctor until the next week. And it really might be doing a toll. We're really trying to figure this out so that we can come up with the best strategy going forward that really benefits our patients, but limits harm too.
So just a couple of things. One, online, people ask why this doesn't have a CD number. This study 17 was actually in development before we switched over to cancer care delivery. And so it's grandfathered into this committee, but it's not a true CCD study, even though it's a CCD question. So I'm answering that for about 3 people that had comments on that. I personally have quite a few patients on this study. I would say a lot of patients have wanted to be on the other arm that you mentioned. They don't want to come in. I'll only go on this study if I can be in the arm that doesn't get scans all the time. So it can go in both directions. I will say that with a little bit of explanation, it doesn't take a lot. Patients are, what we've seen, very interested, especially when you say for these hormone receptor positive first line therapies that they could be on treatment for 3, 4, sometimes 5+ years, and coming in for scans every 3 months may be excessive. And then people start to think about, what this could mean long term. So I think, it's once patients are on, it also does not involve an enormous amount of work compared to a lot of the other studies that we do in SWOG. So I would really encourage sites to think about this because it's an important question. We are going to answer it. And we have made a lot of progress, and it's really not that hard in terms of a site perspective.
And even though this study was grandfathered in, Melissa, you are not going to be a grandmother when this study is done. When this study is done, we're going to we're going to get it done.
I'm a huge supporter of this study, but some of the other oncologists in our group will say, well, I don't want to scan my patient every 3 months, because I think we've moved away a little bit from that. Like, we know they're stable, we know they're doing okay. We might look at it 6 months and then 6 months again. Is there any way to change it to make it a bit more pragmatic on the standard of care? Thinking that 3 months was the standard of care when you originally, I think, designed it, which was true, but now kind of changed a little bit. So
Well, it changed, but not because a lot of the data.
Yeah. And I think, we all kind of in this room want to move away from doing those scans ever so often, because we probably all kind of believe that for patients who are stable, we're really not doing them a service. We just don't have the data to show that. And we're hoping that this is the study that can answer that and to reassure people that that's okay to do. The big concern we had when we were designing the study is, again, we didn't really know what standard of care was. So we pulled the sites, but we wanted to make sure the arms were different. And, when we lengthen that interval, the concern would be that the intervention arm and the control arm were kind of the same.
Thanks. Just some feedback.
No, I really appreciate it. And it's something that we will talk about again internally.
Thank you so much.
Thank you.
Thanks. Our next study is Christine Veenstra's multi-level intervention to promote guideline concordant colorectal cancer surveillance. Christine, are you online?
Thanks.
Yep.
I am. Can you hear me?
Yes. if-
Wonderful.
just let
Thanks
me
very
know-
much.
Let me know when you want to move ahead. I think I have to press the clicker.
Okay, great. You could go to the next slide. Thanks.
Oh, no, maybe it's you. Oh, maybe it's me. Anyway, yeah.
All right, go ahead. Go ahead,
Okay, thank
Christine.
you. Thanks very much. So the study premise here is that we know about 40% of patients with stage 3 colorectal cancer will experience a cancer recurrence despite high quality curative intent treatment. But over half of the colorectal cancer survivors in the US failed to receive guideline concordant surveillance for cancer recurrence. And we know from some work that we and others have done that patients who have a spouse or partner who's engaged in the surveillance process may be more likely to receive guideline concordant surveillance. Next slide, please. So to address this, we've developed a multi-level intervention called Current Together After Cancer, which consists of 2 components. So the first component was an online module that we developed for survivors and their spouse or partners that promotes effective partner engagement that's concordant with patients' preferences. It also helps clinicians include partners in patients' care, and ultimately we hope that it'll improve patients' receipt of colorectal cancer surveillance. This development work was supported by a Hope Foundation Seed Award, for which I am extremely grateful. Next slide, please. The intervention components, again, as I mentioned, there's a dyadic component. It's online, it's for patients, and was initially for their spouse or partner that educates about surveillance. It elicits preference from both the patient and the partner for how the partner might be engaged. It provides dyadic communication training and ultimately provides participants with a tailored checklist of consensus activities. Next slide, please. And we also developed a clinician-facing module, which ideally would be integrated within the electronic health record if possible. It gives the clinician tailored feedback about who the partner is, what that dyad's preferences are for how the partner could be engaged, and then gives some very basic and hopefully simple tailored tips for how the clinician can best facilitate that partner's engagement in the patient's care. Next slide, please. This is just an example of what the facing component looks like. So this is what clinicians will see. And this is populated from data that the dyad puts in through their participation. Next slide, please. We piloted this at the Rogel Cancer Center. We ultimately had 10 patient partner dyads who completed our pilot testing. Next slide, please. And we saw that overall, both patients and partners were very positive about the ease of use and the helpfulness of the online component of the intervention. Next slide, please. So what we're doing right now with additional pilot funds from SWOG, and thank you very much, SWOG has been very generous in helping us to develop this. So we're preparing for an upcoming R01 submission. So the steps that we're taking are, we are currently expanding the content to include non-spouse or partner caregivers. We're hopeful that this will improve the diversity of both the patient and the caregiver population we'll be able to reach and ensure more equitable access to the intervention. We're also creating a web-based version of our existing clinician-facing prototype so that if it can't be integrated into the electronic health record, it can at least be provided on an electronic dashboard. We'll be engaging this summer with SWOG patient and caregiver advocates to determine the best strategies for recruiting patient and caregiver dyads. And then we'll also be engaging with medical oncologists at NCORP practices to elicit their preferences regarding both the content and the delivery method of the clinician-facing component of the intervention. Next slide, please. Okay. So we're hopeful that that work will prepare us for a fall R01 submission to NCI. The overarching goal of the R01 would be to conduct a randomized controlled trial to evaluate the effectiveness of the intervention in improving caregiver engagement and surveillance, and ultimately improving patient receipt of guideline recommended surveillance, while also assessing the factors that influence implementation across community-based oncology practices. So ultimately, we'll hope to partner with 20 NCORP oncology practices to conduct a hybrid type 1 effectiveness implementation study of the intervention. across 800 survivors of stage 3 colorectal cancer, their caregivers, and their oncology clinicians. Next slide, please. Briefly, the aims of the study are to determine the effect of the intervention on the extent of caregiver engagement and patient surveillance, and also on patients' receipt of guideline concordant surveillance. We also want to determine the effect of the intervention on patients and caregivers' satisfaction with how the caregiver is engaged in their care, and also on how aware clinicians are of that dyad's preferences for caregiver engagement. And finally, we'll assess factors related to the use of the intervention across diverse community oncology practices. Next slide, please. And that's all. So thanks very much. Let me know if you have questions.
Does anybody have any questions or concerns or thoughts about this as this study is being developed? Now's the time to provide input, because this is where you can have the biggest impact on how this is going to be designed and moved forward. So does anybody have any concerns about participation in something like this, or the need? We have somebody coming up, Dr. Crew, to the microphone.
So I'm Kathy Crew. We have a very similar study in the Prevention Committee S1904, which is a multi-level intervention, cluster randomized design, targeting both patients and providers. This one is focused on breast cancer chemoprevention. So definitely it's important to keep all the sites engaged. So we have like monthly meetings or virtual meetings. And also we also got a lot of questions from the sites in terms of like building things into the EHR and like just what the technical lift would be. Our particular intervention is not linked to the EHR, but it does use an app that's uses a FHIR API, application programming interface. So there were a lot of questions from the sites about just the security of being able to extract EHR data. So I just think thinking about all of those things ahead of time would be important. And also our outcome was to look at informed choice and shared decision-making at the 6-month visit, but sometimes they don't always see the same provider for that 6-month follow-up visit. So it was also because we were recruiting providers, not just patients, that there are all these other complexities that come with doing cluster randomized designs that I think are important to think about ahead of time.
Kate?
Thank you. Yes. Oh, sorry.
Go ahead, Christine.
Oh, yeah, sorry. Yes, thank you. I was just going to say, yes, thank you. So, and I will follow up with you additionally offline, because really happy to learn from others' experiences here and adjust as we can.
So I have a question for all the sites in the room here. This is Kate Castro from NCI, for those who are on the virtual side of the room. So recruiting dyads, we just talked about this in the credit study. I really would appreciate, and I know the team would too, come forward if there are any barriers or any challenges that you all foresee, because if the study team gets a funded R01, the clock starts and they have to get this study moving. So please come forward and share any feedback you have. We really encourage you to do that.
So hi, I'm Bernard Toffing, medical oncologist at the University of New Mexico, MUN Corp. And we have really struggled with credit for this exact reason, is the dyads. We actually looked at all our screen failures. We screen failed 39 out of 40 patients for that study. And 70% of them was a spousal issue. The spouse wasn't interested, didn't exist, they no longer were married. So this has been a big issue for us. So the dyad will probably be a big issue. And we would probably say no to this trial if it stays as a dyad.
I think that's really important feedback in terms of flexibility. Like that was a lesson learned in terms of thinking about how to be flexible with enrollment and not insisting that everybody have a dyad, because, I think, obviously credit's making a lot of changes to try to, allow for patients that, don't have
No dyad.
because otherwise it won't get done. And what it's actually super interesting that you brought that up, because we also at our site have had patients interested, but their partner not. And so, and that it actually has stopped patients from going on trial, but because they have a caregiver. Yeah.
Yes. Hi, Marie Bacaitis from University of Alabama at Birmingham. Just echoing exactly what you're saying. especially in our area where high underrepresented, under-resourced minority patients. We have probably about a third or less in studies where we've had wanted dyadic interventions of people who had someone that they could identify or would identify as a partner. So we've had to abandon required dyadic use in all of our trials. And I would definitely say you need to figure out another way, unless your area is very different from the areas I've done studies in. Yeah.
Well, and another comment, which is that there is a big disparity, racial disparity in uptake of surveillance. I've learned this from a colleague at the Fred Hutch. And Christine, you might want to think about how you will address minority populations in surveillance and whether additional interventions might be needed to reach them and make sure that the barriers that they face can be addressed.
Yeah, thank you all for this feedback. It's extremely helpful.
Well, thank you.
Next up is patient-centered video education intervention to improve rural cancer care delivery, Randall Holcomb and Izumi Okada.
I don't know if Izumi or Randall, are you on? We may skip this then, because it doesn't look like anybody from the study team is here. I don't know if, you know, we have on our agenda, but no slide that Kathy Crew was going to give an update on her study, but I don't see a slide for it. So I don't know if you mind coming up to the mic and giving an update on S1904.
Sure. So the primary of this trial is in the prevention committee, so you'll hear about it in just the next meeting, but it is also co-sponsored by CCD. And I alluded to it from the prior talk. So S1904 is a cluster randomized control trial of patient and provider decision support to increase breast cancer chemo prevention informed choice in high-risk women with atypical hyperplasia or LCIS. So we've recruited over 85% of the providers and over 2/3 of the patients. And I'll give more updates in the next meeting in terms of, but we're hitting our accrual mark and we hope to finish accrual probably within the next year.
Fantastic. And now Scott's going to give an update on a U34 that was submitted. I don't know if I put it on my screen share. I don't know if you can share this with everybody else in the room.
So I'll just talk briefly while you're getting it up. So this is the payment study. This is led by Veena Shankaran with Dawn and myself as co-investigators. So payment is preventing financial adversity among early stage cancer patients through an unrestricted cash called payment. This was a concept that we originally developed with the idea of it being an R01 submission. And as we were preparing that, we encountered a number of issues that were concerns about feasibility of the trial that led us to reconstruct the proposal as a U34, which is a pilot or a feasibility project. So the specific aim is of that is to conduct qualitative interviews with patients, CRAs, investigators, and staff to understand the barriers and facilitators to financial fragility screening at clinics. We heard a lot of feedback from clinics that the workflow could potentially be a problem in terms of approaching patients and asking them whether they are financially fragile. You can understand there are potential barriers there. So we need to understand workflow issues. We also need to understand whether it is acceptable to patients to being asked about whether they have potential financial difficulties. Because the target of this intervention would be individuals who are at high risk for financial toxicity during their therapy. We also, the intervention was going to be giving them cash cards that they could use for anything they want, basically a debit card. And there was also some concern about using a cash card, whether it would cover the expenses that patients have. For example, it may not work for rent payments, and whether it would be feasible to track their spending using that method. After we do the qualitative interviews, the second aim would be to do a pilot feasibility study after those things have been accounted for, to randomize 50 financially fragile patients to high versus low unrestricted payments. Oh, I should mention that was another issue, is whether people would be willing to be randomized into a high payment where they would get several $1,000s versus a lower payment where they would get some reimbursement, but it was much, much lower. So as part of that, we would track in this feasibility phase with 50 patients, dropout and survey completion rates, and then look at some of the endpoints that we're actually interested in, which is treatment non-adherence, occurrence of financial hardship, unplanned ED and hospital admissions, food and housing insecurity, quality of life, and so on. And then, of course, after we get those 50 patients enrolled, the idea would be get some qualitative feedback, both from the patients and from the clinics that participated, about the experience and impact. So this study was submitted in February, and I believe will be reviewed in June. So we will know whether we are going to get, well, what our score will be at that point. If it gets a favorable score, it would presumably be funded in the fall, and so we would come back at the fall SWOG meeting and let you know about getting it started.
So, and this is a limited site pilot study. So if it does move forward, it will just be in a few sites. There are a few of these U34s that were submitted or are being submitted. Sometimes there's a gap between what you do at your own institution in terms of, you know, a pilot study that you want to do in a bigger way, and then what you might want to do in SWOG in terms of feasibility gaps. And these grant mechanisms are meant to try to close that feasibility gap, for lack of a better way of saying it. I think other committees, several of the other committees have one or so of these going in as well. So you'll probably be hearing about them as well. But not all studies need this. There are plenty that can move forward without it. Just in terms of one or two more updates before we end, we've had several papers published on Tracer over the last 6 months in JAMA Network Open, JCO, and a revision in JOP. So we've made a lot of progress in terms of that as well. So we have the whole spectrum to be proud of.
Should I mention the CTPM?
Oh, yes.
Yeah. So then some of you might remember that almost 2 years ago, we presented an idea for a clinical trials planning meeting with NCI that would focus on screening patients, NCORP patients, for health-related social needs, and following screening, developing a network and a program for putting patients into trials to address those health-related social needs. Rick Bangs was a major participant in that effort alongside me. Ruth Carlos was my and Barbara, and Ruth Carlos was the co-PI for that. We had a meeting in November at NCI where we reviewed the findings. There were multiple committees involved and people throughout the NCORP. At the end, NCI decided that they would not sponsor this clinical trials coordinating center and network, and that their preference would be for sponsoring multiple independent studies focused on different aspects of HSRN. So with that in mind, there won't be a coordinating center for this effort, but some sites will be designing independent studies in HSRN screening and intervention.
Yeah, so there's still a lot of interest. I think that for people that have projects in this sphere, one of the things that came out, at least my understanding, is that it's a little bit too early. A lot of the data and a lot of different important issues aren't quite there yet. And so it's ripe for doing smaller studies, or if you have studies at your institution, to bring them forward. So there's a lot of interest, but I think the intervention space may not be quite there yet.
And there also will be a HSRN coordinating committee that is being created. The purpose of this committee is to review study ideas. It won't have any power about saying, yes, you can submit your study, or no, you can't submit your study. That'll still be with the CCD steering committee. But for those of you who are interested in designing studies of this in this space, that committee would be an option to present your concept to and to get feedback on. Yeah, please.
I think what we learned in the committee was the lack of evidence that there is, right? We had that idea that we were going to be able to work with something, and there wasn't nothing, a lot of publications or anything specifically or standardized. Things we did discuss when we had the different committees was that just by giving the thermometer or other screening, even if it didn't mean paying the patient or helping the patient with housing or food, it really helped adapt maybe the treatments. If this person did not have transportation, they could spread it out for 4 weeks instead of 3 and things like that. So just by giving the screening helps. So I think there's a lot of opportunities to really understand how we can help patients.
I would so agree with that. I mean, this is another one of those situations that was a little personally frustrated for me. You can think of a lot of reasons why this might not work, screening, and there's we've mentioned many barriers at this meeting, but we also mentioned that there is a huge need to address this problem with patients. And so the need for research, the need for understanding the barriers and how we can address them remains. But there won't be a coordinated effort to address this, but that doesn't mean that we can't submit individual concepts either through the steering committee or as R01s or other funded projects.
With that, we want to thank everybody for showing up at 7 a.m. And for all of the 50 plus people that joined us online. I think there's a lot to be proud of in this committee, and we really encourage anybody with any ideas to bring them forward. You don't need to wait till the next meeting. Send us an email, and we're here to help. So enjoy the rest of the meeting.
Thanks for coming.